Hi, thanks so much for having me here today to talk about the NYU training program in psychedelic psychotherapy. I want to thank Kevin and Neil for bringing everyone here together and all the people that have helped in this, and also all the therapists and other people at NYU that have contributed to our program. I'm going to talk today about a training program that's affiliated with an academic research program and working with people who have cancer. So this is not a talk about training to become a psychedelic psychotherapist for a broad population of people or for a non-clinical, a non-research population. We train to do a very specific thing in a very specific setting. I'm Jeffrey GUSS. I am an investigator and the director of psychedelic psychotherapy training at the NYU Psilocybin and Cancer Anxiety Project. Today, I'm going to divide my talk into three sections. The first is a little bit of a sort of an overview and a thought piece about what psychedelic psychotherapy is, who does it, how people train to become one, and where it is in our Western culture. The second is the structure of the NYU training program, and the third and last part, the goals of the training program. You might think that the goals would come first, but actually the goals for the training program evolved over the first year that we were doing the training and doing the research, because it wasn't entirely clear what we needed to learn and what we needed to do until we actually started to do it with subjects. So to begin, who does psychedelic psychotherapy today? What happens for a therapist and a patient during a psychedelic psychotherapy session? And what are the theories? Are there theories that we could say underlie a psychedelic psychotherapy process? And what does the person do in order to become one? So in thinking about how to address this question, I decided to work with 4 different kinds of therapists, or people who engage in a therapeutic way with participants or subjects or seekers or individuals that offer some kind of psychedelic psychotherapy. And there are 4 categories that I'd like to talk about: the shaman, the neo-shaman, the meditation adept, and the palliative care psychotherapist, or the psychodynamic psychotherapist. Now I'm going to talk about each category, and each one of these categories, as I'm sure the people in this room know, is a very diverse, complicated group of people, and it's really wrong to say, okay, shamans are this way or neo-shamans are that way. So I'm going to offer some generalizations, which may even sound like stereotypes to some people, but I ask you to bear with me because I want to try to bring out some principles about what it is that we are training people to do at NYU, the limitations that we have, the opportunities that we have, and how we are different and in some ways similar to each of these 4 categories. Shamanism is humankind's earliest and longest lasting healing, psychotherapeutic, and religious tradition. The core function and one of the core theories underlying shamanism is communication with the spirit world. The shaman interacts with unseen, mysterious forces. So right off the bat, we have a kind of discourse which is prohibited in Western medical settings. If you say to someone, I want to help this patient by giving them this medicine, or I'm going to take this medicine which is going to allow me into the spirit world where I can communicate with spirits and help solve their problem, you're not going to get very far, you're not going to get any referrals, and you're really going to be considered to be not even a fringe player in an academic medical setting. You're going to be considered a kook, and you're not going to be taken seriously. And I'm going to repeat again and again, we are an academic research program in a medical setting. We have our place that we've landed, and we're trying very hard to make certain that we continue to be welcomed and taken seriously in that setting. So we can't be all things to all people, and I think that there are certainly ways that some psychedelic psychotherapists would say what we're doing is, misses the mark in terms of what the general practice would be. But we're doing what we're doing where we're doing it. The shaman enters a trance state, in an altered state of consciousness, sometimes with the drug, other times without. The shaman experiences soul or spirit leaving the body and journeying into other realms. And this is quite a literal use of language within shamanism, that the soul leaves, journeys, does something, communicates, doesn't make some kind of a deal, negotiates, or retrieves the soul and brings it back. The shaman commands, intercedes, and communes with spirits for the benefit of the individual or possibly for the tribe. So again, we're quite distant from the way that Western medicine thinks about psychotherapy and in particular medical therapy. There is a commonality, though, between the shaman and the psychoanalyst. Both suffer from a malady which is defined by and cured by a particular practice. Everybody who becomes a psychoanalyst has a condition which is, by definition, if not healed, certainly treated and ameliorated by the practice that the psychoanalyst is learning himself or herself. And the same is true for the shaman. So the shaman and the psychoanalyst share the wounded healer paradigm. I had many, many slides before this one, and in the interest of time, I pared them down, but I wanted to include this one because it brings quite a profound aspect to bear, which I'm going to talk about through today's talk. And that is the culmination of the shamanic quest. Shamanic training program is a very extensive program. It usually takes a number of years. Occasionally it's brief, but commonly it takes a number of years. And there's a confrontation with death, and this is experienced quite literally as a death of the individual, a death of the soul, a death of the body, with transformation and rebirth. These themes are not heard very often in how medicines work with people who are suffering from anxiety, but for the NYU therapists, our training involved turning our attention to the theme of death and transformation again and again and again, because so much in our psychotherapy training, we think of the patient as leaving us and having a long life to live, leaving us with an open-ended potential for using what they've learned and using the transformations that have happened to them in our work. But in order to be therapists in this study, we had to learn to face death, think about our own death, and think in a very unblinking way about the death of people who came to us for help and people who had cancer. Now, I don't need to tell people in this room that there often are psychedelic plants that are part of shamanic training. The training may involve taking psychedelic medicines and may involve taking a lot of psychedelic medicines. And the practice may be either, the sacrament, the psychedelic may be taken by the shaman or the patient or both in the healing process. And there already has been a question about who takes the substance and who knows what. In shamanism, sometimes the shaman, sometimes the patient take the medicine, but certainly in training, the shaman takes it. A similarity between shamanic training and Western training is that there are culturally bound narratives of illness and healing. In other words, a shaman may be a marginal figure in society, but they are a well-recognized figure, like a neurosurgeon. Not that many people actually go to a neurosurgeon, but we all know what a neurosurgeon is, we know what a certain neurosurgeon does, and there might come a time in which we need one. So it's actually a fringe person in most people's lives, but an idea or a presence in lives. And again, there is a highly ritualized, strong respect for tradition. In psychedelic shamanism, plants are considered a gift of the gods. They're the mediator between human beings and gods, or the psychedelic plant may be the god itself or himself or herself, and the plants contain spirit power. In psychedelic research and in psychiatric research, molecules are considered inert substances. They're dangerous. They are in danger. We have an 800-pound safe that protects the psilocybin in our study, and it's always curious to me, like whether it's being protected from us or we're being protected from it. But in one case or another, this huge safe is required to keep this tiny bottle of medicine. That's the way it is on First Avenue, 26th Street. But in other places, they grow out, in the wild for anybody who wants to go pick them and take them. So this is a summary of what the indigenous shaman brings. The neo-shaman is somebody who's more a member of a contemporary Western society, and the core text on neo-shamanism is Michael Harner's The Way of the Shaman. The neo-shamanic beliefs include direct contact with the spirit world, including entering altered states through psychedelic medicine. There's skepticism towards monotheistic religions. There's skepticism towards traditional allopathic medicine, in particular psychiatry, and usually a good bit of skepticism towards the scientific method as a way of knowing. The psychedelic sitter or the neo-shaman is generally naturally emergent and self-selected, as opposed to a shaman who is sort of selected by the community or whose qualities as a shaman are emergent, and there isn't always a voluntary choice for each person that's called into shamanism. The validity to function as a neo-shaman or a psychedelic sitter is based on personal experience with psychedelics and often little more, and there is a lack of a formal, widely accepted, culturally bound apprenticeship process. The neo-shaman is often allied with yoga, chakra healing, Chinese medicine or acupuncture, astrology, or a broad variety of other non-traditional healing mechanisms. The neo-shaman, or the psychedelic sitter, is a culturally deviant identity. If you are a psychedelic sitter, you may be able to talk about that in a room like this, but there are many, many worlds in which, if you talk about that, you're going to be held in question. And I like this picture because, this woman could be at Burning Man in a tent, or she could be a junior league participant, or she could be both. And she could be a psychedelic sitter and a neo-shaman. You can't tell by looking at her. And in most cultures that have shamanism as a central healing mechanism, the shaman is not a hidden identity. We have a bridge between neo-shamanism and psychiatry, and that is Stan Grof. Oh, I thought I put his 2 books in. Looks like I didn't. And Stan Grof's writings are very, very interesting, and he brings forward the idea of death and rebirth. His perinatal matrices, being in the womb, the contractions prior to birth, exiting through the birth canal, and then being born, apply in a metaphorical way to 4 discrete processes in human transformation that he uses when he does psychedelic work. But again, we see the theme of death and rebirth coming forward. Being a neo-shaman is a prohibited discourse in medical circles. In other words, you really can't talk about being a psychedelic sitter if you want to be taken seriously as an academic researcher or as a participant in academic research. And this is one of my pet peeves, if you get the pun. This is a PET scan. It's much more comfortable for people to think about scans like this, although in my opinion, a PET scan is just the slightest bit less metaphoric about how the mind works than chakra healing or acupuncture meridians. So then we have a review of neo-shamans. Mindfulness. The mindfulness adept, or the meditation practitioner, or the meditation teacher, offers something very specific that we used in our study, and that is the skill of mindfulness. Meditation teaches a technique for developing mindfulness, which is characterized by 2 main qualities: the self-regulation of attention and the focus on the immediate experience. The focus on immediate experience carries with it a particular kind of orientation, and that is an orientation of curiosity, openness, and acceptance. Working against the absence of curiosity, oh, I've already seen that, I already know that. Openness, no, I don't want to feel that. And acceptance, no, I can't bear feeling that. Each one of these habits of mind is countered through the technique of mindfulness. Mindfulness is not blissing out and having only good thoughts. It is a kind of a relationship with one's own thoughts. And this is a central technique that the therapists use in the research program. Mindfulness is a core practice in our medically based psychedelic psychotherapy. The mindfulness practitioner recognizes that altered states of consciousness have the capacity to facilitate a transformation. However, in many advanced meditative practices, there is a deep skepticism of drug-induced altered states of consciousness as less legitimate, as not leading to a religious life, just a religious experience, and just being not kosher in some important ways. So this is a review of some of the qualities of mindfulness and the same. And the 4th I'm going to talk about is the palliative care therapist and the psychodynamic therapist. We have in our study 3 2-hour preparatory sessions before the first psychedelic or placebo session. Then there's 7 weeks during which there's 6 more hours of therapy. Then after the second session, another 6 hours. And we had to come up with some clarity about what we were going to do during all that time when we were working with people with cancer-related anxiety. And if you look at the palliative care literature, one of the core processes that is promoted, in addition to mindfulness, is the development of meanings and narratives regarding illness, cancer, and death. And this was a great asset when I discovered it in the palliative care literature, because it was new to me when I started working with this project. There's a similarity between the original radical idea of psychoanalysis that Freud brought. It has been so changed and so developed in so many different ways that some people forget that Freud's hovering, free-floating attention is actually quite similar to the meditative mindfulness that I spoke about just a couple of minutes ago. Also, in Freud's original psychoanalysis, there was a search for truth, authenticity, noetic awareness, and surrender. And noetic awareness of the truth is knowing and feeling the truth without a need for objective proof or external validation. Mindfulness in palliative care anchors the individual in reality, in immediacy, and groundlessness, which includes the inevitability of change, letting go, and the tolerance of intense emotions. One of the qualities between palliative care and psychoanalytic therapy shamanism is the intense focus on self-observation by the therapist of their own feelings, thoughts, breath, and bodily sensation in terms of maintaining presence and also being able to be most therapeutic to the patient. The therapist's own psychotherapy is an integral part of the training process. And importantly, this is quite consistent with Western medical ethical norms and standards and is easily accepted. And we have 2 slides of review. So I'm going to go on to talk about the structure of the program. I modeled the training program on the psychoanalytic training, which is composed of 3 essential components. The first is didactic coursework. In psychoanalytic training, you have years of articles, chapters, books, and discussion studying the writings of other people. You have 3, 4, or 5 carefully supervised control cases and a personal psychoanalysis. So if you think about modeling psychedelic psychotherapy training on this, we have a problem. And the problem is that personal work with psychedelic medicines in a supervised, regulated way is not something which, at this stage in the evolution of the psychedelic research renaissance, that we can have. There is no legitimate way that we can require therapists to undergo psychedelic psychotherapy, and really no legitimate way in which we can even talk about it. So it is a prohibited discourse, and all I can say is that it leaves this aspect of our training program incomplete. There are some substitutes that we considered. We could have encouraged our therapists to undergo secret entheogen experience and not talk about it, and that seems really bogus to me. We talked about holotropic breath work, but this is not really the same thing as psychedelic work, and we wanted our therapists to feel free to pursue whatever kinds of meditative, spiritual, transformative experiences that they chose to pursue their own spiritual path and not set a certain kind of standard for what it should be. Also, as I'm sure many of you know, in August 2010, MAPS was successful in developing a program by which the therapists in an MDMA study for PTSD will be allowed to take MDMA as part of their training as a study program looking at the psychological effects on healthy volunteers. But this is really not part of our agenda at NYU at this time. So I thought about what I might substitute for it. And what I found, what I developed, actually doesn't really substitute for direct experience with psychedelics in terms of what that might offer a therapist. But it does offer something which I think is of real value to people. And that is the experiential DYAD sessions. Now, some of you may know, but all of you may not know, that the therapy that we do with subjects in the study is done by therapy teams. Each person in our study is assigned a therapy dyad. Usually that's been a male-female dyad, although recently we have had a male-male dyad. And we wondered what the communication process, what the development process for the therapy dyad should look like and would be. So I developed these dyadic sessions. And so this is an overview of the 3 components of the NYU training program: didactic, reading, classes, articles, the experiential dyad sessions, and supervision. And I'll talk about each of these individually. The didactic first. The didactic coursework occurred over a 9-month period. All the therapists participated in it. There were 18 sessions over about 9 months. For many of us, it was a crash course in palliative care psychotherapy. Only Tony Bassis, who is a palliative care specialist and a pain medicine specialist, had been working with individuals who have cancer, who have pain, and so he was well experienced in palliative care, but it was new for all the rest of us. And it was quite eye-opening to me to study palliative care, to find articles that I thought would allow the therapists to quickly get up to speed in the methods, techniques, and theory for it. We read 1 academic journal article or book per session, and in class we talked about how to apply what we were learning about palliative care therapy to what we imagined psychedelic therapy would be, because our training occurred before we actually had started working with our subjects. And it happened here in our study room. So we started reading Ira Byock's article, The Meaning and Value of Death. And this is actually one of the most moving and touching sessions I think that we had. This brought forward so many reactions in the therapists, things that we had not thought about, not talked about, and discovered that we had, in a way, like so many other therapists, had a subtle, maybe not so subtle, denial of the impact and meaning of death, our own death, the death of our patients, and the role of death and the denial of death in the therapy that we do. I had never learned to take a spiritual history, and so we read a couple of articles on that, in particular Christina Puchalski's article on spirituality and the care of patients at the end of life, and we each practiced doing spiritual histories and taking them on one another. We read Bill Breitbart's article, which gave a very nice introduction to existential psychotherapy with its focus on freedom and death, and the denial of freedom and death, as well as logotherapy by Viktor Frankl. We studied the historical perspectives on the work that we're doing, reading Stan Groff and Joan Halifax's chapter, The History of Psychedelic Therapy with the Dying, and Pankey's classic article, The Psychedelic Mystical Experience in the Human Encounter with Death. There were a number of interesting articles that we read, that I looked at, and this is one of the best, looking at spontaneously occurring or evoked mystical experiences with people who have cancer. And Alison Vitta, I think is how you should pronounce her name, works in palliative care, does not work with psychedelics, but looked at spontaneously occurring and evoked mystical experiences with people who have cancer, trying to help figure out what makes them happen, what facilitates them, what shuts them down, but most importantly, what's important about integrating them into the overall psychotherapeutic approach to the individual with cancer. We studied mindfulness and breathing practices. Again, this article by Ann Bruce focuses not just on learning how to teach a breathing practice to your patient, but how to participate yourself in the palliative care work as a form of meditation, tracking your own awareness and mindfulness as well as that of your patient, and realizing that the separation between your mindfulness and your attention to your patient's mindfulness, the barrier between subject and object, begins to break down. And I think we see here a bit of a connection to the breakdown between the subject and object that we saw in traditional indigenous shamanism. When I studied palliative care, about a third of the articles that I found were about burnout. And I learned how quickly people who practice palliative care burn out and find the work unbearable. There are a lot of articles about preventing burnout and how to maintain yourself as a practitioner. In order to figure out what to do during those long sessions, those long therapy sessions in between the first and second experimental medicine sessions, we used two forms of therapy, two kinds of structured therapy. One, meaning-making therapy, and the other, life review therapy. Both of these help look at the person's life as a whole, beginning with birth, moving to cancer, ending when that person imagines their death is going to occur, looking at how they coped, goals, disappointments, strengths, coping strategies, vulnerabilities, creating a new and different narrative about this to help the person cope with both their present and what they were going to do with the remainder of their life. And the Life Review Interviewing Guide by Beecham was a really great article and really, really interesting in terms of how to work with the stories that were being given. Not just to take them in a kind of empathic attunement to them, but also how to work with them and give something back to the patient or the subject that really felt useful and creative, and not simply holding what they were telling you. We had some guest lecturers. Bill Richards from Johns Hopkins came and spent a weekend with us, and we still refer to the notes from that weekend. It's really quite a brilliant and moving and touching experience spending time with him. I learned a great deal about how to conduct the sessions, how to interpret what happens, how to deal with problems, how to prepare ourselves for it. So it was really a great, inspiring experience. Scott Kellogg from the Department of Psychology at NYU gave us a talk on transformational chair work, and Oliver Williams and Emily Horowitz gave us a guest lecture on holotropic breath work. So next, I'm going to talk about the experiential DYAD sessions. There were 6 experiential DYAD sessions. There are 8 therapists in the study. There are 4 DYADs. And each dyad was fixed. They were invited and actually required to complete these 6 sessions. The sessions lasted 1.5 to 2 hours, and only the therapists were present during the experiential DYAD sessions. Each session had a defined theme, although a free-flowing discussion occurred afterwards, after beginning with the theme of the session. At least it certainly did in mine, and I think it did in other people's DYADs too. After the 3rd and the 6th session, there was supervision with the person who was designated to be the supervisor. I was not the supervisor for all of the DYAD processes because there was just too much supervision to do, and we felt that it'd be useful for people to talk, in a way that felt comfortable and in a structure that had some flexibility for who wanted to work with whom. The goal of the DYAD sessions was to establish a close communication and close connection between the therapists and to discover similarities and differences, not just in their therapeutic styles, but also what they thought and felt about the afterlife, about heaven and hell and so forth. When I was selecting the pictures for this, I didn't think that much about this particular one, and it seemed a little cutesy, but just last night when I was reviewing my notes, I noticed that when you played this game of speaking with a tin can, who's listening and who is speaking is very well defined. These people cannot have a conversation. Who's listening and who's speaking is defined, and this actually was one of the ways that the sessions were structured. I invited the therapist to speak as if they were the patient, or the subject, I keep calling them the patient, the subject in the study, talking about their internal experience, and for the other to function as a therapist and practice the kind of active listening skills that we were going to be using with our subject. The first session was about early memories as well as contemporary experiences of death and losses. I invited people to talk about whether as a child they had family members that died, pets, friends, patients, parents that had died. Also early memories of awareness that you yourself are going to die, when that first came about, and the reaction or the defense or the denial or whatever it is that came up around that really frightening awareness. The second session was to talk about experiences with profound spiritual, mystical states and entheogen experiences. Now, many of the people in the room here will probably easily recognize what this is a picture of. These are people from North America or Europe who have traveled to South America to engage in ayahuasca retreat and have experience with that sacrament and that healing system. This was a place in the privacy of the DYAD sessions. People were free to talk about what they had done, what they had not done, what they were afraid of, what they wanted, what they didn't have, what they did have, so that in this private and confidential setting, there was a freedom to be quite open. I also invited each therapist to talk about their experiences as a sitter, if they had done psychedelic therapy with people, or if they had had experiences with psychedelics and worked with the sitter, what that was like, what they didn't like, how it worked, how they understood it, and how their role in the study was different or similar to what they experienced themselves. And also to talk about whether they work with shamans. The third session, the therapists were invited to talk about their experience of pain and suffering in family members, friends, and patients. This is different from death and loss. This is about being in the presence of ongoing anguish, pain, and suffering. Also, for each person to talk about experiences with their own cancer, or family members, friends, patients that had cancer, or other terminal conditions, as well as disfigurement and body failure. Now, I had not worked in the inpatient unit for many, many years before working with this. And although in my medical training and in my residency, I saw a lot of very, very sick people. It had been a long time since I'd been with somebody who was really quite ill. And often as a doctor, when you work with somebody who's really quite ill, there's a technological or diagnostic or treatment intervention that stands between you and real empathic immersion with what the patient is going through. You're prescribing something, you're relieving pain with a pill, you're diagnosing what's making them hurt so much and trying to relieve it. And the job of empathic immersion with your subject who might be in agony or in some kind of anguish required a kind of tolerance that brought a new challenge to me, and I think to a number of the therapists in the study. The fourth session was focused on near-death experiences, whether the therapist had ever had a suicide attempt or had suicidal ideation, whether they had, in their spiritual practice, had ever had an experience of dying, body decomposition, and transformation, including these experiences that might have occurred through entheogens. Also, I encouraged people to talk about being ill or having an accident or having any kind of near-death experience, so that the therapist would know what their partner was really about when it comes to these real life and death issues. The fifth session was devoted to personal beliefs about heaven and hell. Some of our therapists believed quite literally in a certain kind of afterlife. Others had absolutely no belief or no sense that the consciousness lives on in any way after we stop living. I encouraged them to talk about their religious history, work that they'd done with religious or deeply spiritual patients, and what happened to them growing up, whether they were alienated or estranged or perhaps even still a deep practitioner of some kind of organized religion. And the sixth session was devoted to personal experiences with extreme emotional states during psychotherapy. Whether we had, the therapist had worked with people who were terrorized, grief-stricken, rageful, people who had bizarre, altered somatic states, somatic hallucinations, or agitated states, and experiences in friends, loved ones, family members that had been in such states. We did not experience this. We really anticipated that there might be quite extreme behavior coming from the subject in the study, and there certainly has been crying, fear, anger, a lot of intense emotion, but we've not had any disruptive experiences which in any way felt anxiety-provoking to the therapist. And quite the contrary, the emotional outbursts have been deeply moving and really, I think, very healing for the subjects, and really profound for the therapists as well. So the lived experience of the experiential DYAD sessions. The topics that I set up were really just a starting off point, and people went in all different directions in their DYAD sessions. The supervision was necessary in order to track how the DYAD was doing and whether they were progressing along and what was required, but there was a subtle intrusiveness, I think, at times by the supervisor, and it does not adequately parallel the personal analysis that's central to psychoanalytic training. So I'm going to close by reviewing the goals of the training program. The first goal, developing core competence in the methods of palliative care psychotherapy in individuals with advanced cancer. The second, developing a close, trusting, flexible bond between the co-therapists. Third, the development of the capacity to support a mystical or spiritual experience in the subject and relate these to the illness and the mortality that's facing the individual. This was really something quite new for me. Although I have been involved in spiritual practice for a long time, working with it in patients and applying it to transformation in their life was something that was new for me, and something for which I'd had a kind of distance in terms of the practice that I had of psychotherapy and what I was doing myself. Learning how to recognize it and support it in patients and use it creatively, it opened up a new way of talking and helping the patient. And we had to not only learn how to do that, but also relate it to cancer and the fact that the individual was going to be dying of cancer, and perhaps in the near future. We wanted to develop skills in how to respond in a very specific way to difficult, complicated, or disruptive experiences. We talked for long periods of time about touching, and whether it was right to touch someone or not touch them, and do we need to ask them for permission during the sessions. And after all the talking that we did about it, I think there's been a significant amount of hugging that's gone on when people were in extreme states, and I think that everybody's all the better for it. So we developed these skills, but I think that people did what came naturally in terms of caring about people when they were in rough shape or in extreme states, and it's not been a big problem. Another goal was to integrate personal experiences with mystical states and your identity as a spiritual seeker or an entheogen user with your identity as a palliative care and transpersonal therapist. There was a surprising amount of countertransference that emerged both in our work group and in sessions with, actually it's not surprising that it occurred, but there was a lot of it that occurred, and we learned to work with that. And lastly, developing acceptance of the restrictions imposed by the fact that this is a research protocol. As I said at the beginning, this is a training program in psychedelic psychotherapy for people with cancer in an academic research program. There are many things that you would not do if this were outside of a research setting or if the individuals didn't have cancer. So, you know, when you become a psychoanalyst, you're free to go out and treat all kinds of people, and you're not trained to be a psychoanalyst for this particular kind of condition. But I wanted us to focus on what these subjects needed in this setting at this time, and that's the training program that we developed. There were a number of things that we had to do that felt intrusive into what would ideally be the most empathically and carefully crafted psychedelic therapy session for patients. There were also things that we couldn't do that we would like to have done. All of these had to be tailored in order to maintain the integrity of the research program, because in a way we had subjects in our study, but the most delicate and the most fragile subject of all turns out to be the study itself. The study itself requires a tremendous amount of caretaking, tender loving care, attention. Sometimes it seems like it almost needs life support to keep going because of all the challenges that come to it. And so there's really not many days go by that we don't have to remember that we're not just psychedelic therapists, we are researchers in an academic setting. I brought a lot of this together in a training manual, which has the didactic components, the experiential components, describe the preparatory sessions with the subject and the family, the experimental sessions with the subjects, and some guidelines on how to conduct integrative sessions with the subject and family. So some long-term questions include questions that are the kind of things that are asked in departments of psychiatry and academic medicine whenever you offer a new form of therapy. If you offer a new form of therapy, you have to define what are the core processes that define that therapy. What makes that a particular form of therapy that's distinct from other therapies? Is it possible to establish standards of practice? You know, that phrase may sound very boring and foreign to people who are not involved in academic research settings or academic training settings, but it's all over the place in departments of psychiatry. How do you say, okay, this person is trained as a psychedelic psychotherapist and they've met the standards of practice. They're doing what a competent psychedelic therapist should do, and this person isn't. This person is behaving outside those boundaries. And setting those boundaries and deciding like who's making the cut and who's not is what training programs, these are questions that you have to answer. We need to think about whether countertransference is understood in any way that's different than any other form of therapy. Are two therapists really necessary for this process? Is the male-female dyad tradition one that's valid and should be maintained? Is it possible to evaluate the clinician's spiritual maturity? You know, when you train to be an analyst, your supervisors will say, yes, this person seems to have achieved an analytic process, they know how to handle it, and they're mature in an analytic way. Is it possible to say that about another person's spirituality? Because it seems to me that spiritual maturity should be a prerequisite, not a prerequisite, but an accompaniment of being a psychedelic therapist. A big question that intrigues me is how character structure affects response to psychedelics and psychedelic therapy, and how do the therapist's values and psychological orientation theories affect their work. So, as I guess you can see, I really like looking at images, and because I think that they convey something that the words can't. And when I saw this picture, I thought it was really quite funny and captured something about the way that I think many people see our program. Ours is not a psilocybin research study. It is a palliative care study that is assisted by one dose of psilocybin. The person has two experimental sessions. One is placebo and one is active drug. So the concept that this is all about what happens inside this molecule is, really not accurate, because there's so much work that happens with each subject that does not involve the actual ingestion of the substance. On the other hand, psilocybin pervades every aspect of the study. It gives us the way to build a bridge and to enter medical discourse with psilocybin on our lips, to talk about it, to bring up the topic, to explain to doctors and nurses and social workers why we think this might be helpful to them. We go into the most traditional of Western medical settings and talk about it. So before I talked about a prohibited medical discourse, this study is a way that we are making psilocybin and psychedelic therapy part of an accepted medical discourse. So, as I mentioned before, there are very few actual encounters between the human being and the psychedelic agent, and yet the spirit of the agent pervades all aspects of the process, from the initial phone call throughout the entire process with us, and even the follow-up afterwards. I also just found this very funny slide last night, and wondered whether the brain was generating God and Adam, or God and Adam had generated the brain, or whether these were just two among many metaphors that we can use to think about, what happens up here. But the goal of this project and the goal of the training is to bring together and to create a discourse between these two worlds, the worlds of academic medicine and the world of psychedelic medicines, and in particular, the suffering that's caused by cancer, death, and dying. And the themes of the altered narrative that we try to bring to the subjects also, I think, have come about for all of the therapists in the study. And that is the importance of having a sense of contribution to other people, the importance of forgiveness and acceptance of each other and ourselves for all of the challenges and mistakes and hardships and difficulties that come our way, the sacredness of life and each moment of life, preparing for experiences of death and rebirth, and a moment-to-moment appreciation of each moment of life. And with that, I'll bring it to a close. Thank you. Questions?
Thank you, Jeff. Beautiful. Questions? Miss.
Hi, my name is Dr. Deborah Goldberg, and a while ago I was boarded as a medical oncologist, and I'm also a medical hypnotist, so that's my framework. And I'm really glad you guys are doing this study. I think it's really important that it be done. But my question has to do with, is psychoanalytic training in this whole thing a surrogate for maturity and discipline? Or is there something about psychoanalytic training that's really necessary, in your opinion, to be able to be somebody to evaluate this data?
Training somebody to evaluate?
In other words, is the psychoanalytic training a necessary part of looking how to do this kind of therapy? We're using the possibility of using psilocybin to treat cancer, near-death anxiety. Do you need the psychoanalytic training, quad training, or do you need it because you get the right people out of doing it? That's really my question.
I think it's a great question. I don't think you need psychoanalytic training per se, but I do think that you need extensive training as a psychotherapist. I think you need to know how to work with all kinds of people in all kinds of extreme states, how to work with transference and countertransference, have a sense of your own, of yourself as a therapeutic instrument in working with people. We have people who are social workers, psychologists, family therapists. Some people work in a family network, strategic, structural family therapy model. Others are more psychodynamic. It isn't what the training is as much as having had experience in sitting with a lot of people in pain over time, and knowing who you are and the process that you believe in. Because if you know the distinction between psycholytic and psychedelic psychotherapy, I think our subjects have a combination of both. In many ways, they have a loosening of the defenses and the kind of aggression that Groff and others wrote about in terms of psycholytic psychotherapy. And when those defenses loosen and the person is in a kind of a psychodynamic session with you, you have to know what you're doing, why you're doing it, how to take a person from here to there. And the theory that you have doesn't matter as much as your confidence and ability to do that. So you have to spend a lot of time as a therapist. And I don't think just doing a lot of psychedelics yourself makes you able to do that. It might make you able to interpret in one session something, or know how to understand or identify with what your subject is going through. But as I said, so much of what happens is about palliative care therapy. So it's mostly about being settled as a therapist and being ready to understand and work with what happens in sessions.
Excellent. Other questions, please? Front.
Just to go along with what you were just discussing, what sort of people have entered the program and succeeded? Like, what were their backgrounds as far as the people that have been trained in the palliative care program?
You mean the therapists?
Yes, the therapists.
All of the therapists are either psychologists, social workers, family therapists, psychiatrists. So everybody's been through a training program in some kind of psychotherapy and had extensive experience in working with people outside of psychedelic psychotherapy. So this is sort of an integration of an interest and belief in psychedelics with pre-existing identity as a therapist. Does that answer your question? Okay.
Room. Yes.
I wondered if you followed your subjects until death. Did you follow your subjects all the way through to their death?
Yes. Not all of them have died, but all of them have been followed, and some treatment, the research itself ends at 9 months, and if it appears clinically indicated, there's no rule against the therapist and the person continuing to see each other in some form, but there's a structured interaction with them, and there's also a sort of compassionate clause in which we're able to see people in ways that seem, clinically indicated. We had one subject that lived in California who flew to New York for his sessions, and about 3 or 4 weeks before he died, we were really fortunate enough, because a very generous person at Bluestone supported his therapist, which was me, and my co-therapist and our research coordinator, to fly out there and see him in his home. So we were able to see him just a few weeks before he died.
I've got a couple of. So I have a couple of questions. Could you tell us the other kinds of doses of psilocybin you were giving? And also, I was wondering how you were going to be assessing the quality of their psychedelic experience.
It was 34 milligrams per kilogram, 0.34 milligrams per kilogram. So it's done on a milligram per kilogram basis, and each person gets the exact same dosage in their session. People are extensively evaluated through a broad variety of questionnaires before, during, and after. They're given the APZ questionnaire and a number of other instruments. I can't list them all for you, so sorry.
Other questions? Sir. Excuse me, could you pass this down?
So you mentioned that there was a bit of countertransference, and you also mentioned that you have an agent, or somebody who goes with the patient throughout the process from the beginning to the end. And I was wondering if you examined at all the therapeutic alliance, and if your thoughts on that and its role within psychedelic research.
It's a big question. Examined, yes. Studied in a research way, no. All of our studies are focused on the experience of the subject. Even the person, even the family members that we work with are observing the subject in the study. So we have no systematic way of looking at what the therapists are going through or what the family members or loved ones of the subject are going through. But examined, yes, that's something that we work with in supervision. And the transference and countertransference, for the most part, is similar to other ways that transference and countertransference emerge. The patients can see you as either father, mother, their kids. Since there's two therapists, there often is a kind of split, and one person becomes warm and caring, and the other one is cool and distant. You know, all kinds of processes like that happen. One of the subjects that I worked with was young. And he was younger than I am, and he's a gay man who was very muscular, and throughout the time I worked with him, I saw him shrink and shrink, and watching this happen, I think evoked a reaction in me that was different than if my subject had been a 75-year-old woman with cervical cancer, because my identification with him was so much stronger. In one of our sessions, he had to catheterize himself, and seeing that, and being present for that, and seeing the pain and anguish and suffering of this process was wrenching. It was really painful to watch that, and for him to not do that alone, but to do that with somebody that he had a relationship with. It was a complex transference, countertransference event for us. Does that answer your question? I'm sorry, I can't hear you. Okay.
Yeah, hi Jeff. I have a question. I think your therapist training program is fantastic. And so I wonder though, do you videotape your sessions, and is there some way for you to kind of verify or give feedback on whether people are following the principles that you've tried to teach them? Right. And then secondly, in the MDMA PTSD therapy training program, we've gotten, as you know, permission from FDA to give MDMA to therapists as part of their training. Are you going to be exploring trying to get permission like that to administer psilocybin to your therapist teams?
Okay, so let me see if I can remember all the questions. No, we don't have any videotaping of the process. We considered that, but we decided it would be too intrusive for the subject. And the idea that they were being recorded without any knowledge of what would happen to that recording would have a detrimental and profound effect upon their freedom to be, say, do whatever it is that they were going through. Now, I know often, people will say, well, I forgot about it after 5 minutes. I certainly, heard that from patients when I used audio taping during my analytic training. But as a group, we just decided to put that off. And to answer the second part of your question, no, we do not have a plan in mind to develop research similar to the MDMA research. It's not a way that we're leaning in terms of how we want to devote our resources, time, and energy right now. It's not that I don't think it's important. I do. But we're all volunteers, and we have limited resources and limited time, and it's just not made it to the top of the list in terms of projects that we want to pursue. So no, I don't have any way of validating that people are following the principles except the supervisory process. This is something which is just beginning, and you can't do everything all at the beginning. I think it would take training more people and treating more subjects to really know more about what psychedelic therapy is, what these particular patients need, what therapists need, and so forth. It was a challenge to develop a training program for a kind of therapy that was not really very much in existence yet. So it's sort of like getting not the cart before the horse, but like getting the saddle before the cart and the horse. Because you've got to figure out exactly what it is that you think you're going to need before you actually need it. And we've been evolving it over time, the more subjects we treat.
Thank you. I think we're really out of time for questions right now. And please help me thank Jeff GUSS.